said hard of hearing for 1 year, sir. There's no other history of ear pain or ear itching, and no other negative history, sir. On to the examination. Patient is conscious and oriented, sir. Moderately built and nourished, and with no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema, and efebrile. Pulse rate was 76 per minute. Blood pressure was 110 by 80 mmHg, and respiratory rate was 18 per minute, and it is regular. Systemic examination, the cardiovascular system S1, S2.
So 1 minute. Go back to your previous slide. So what is the importance of doing general examination in a ear case? Let us say, I'll just discuss only one point. When will there be pallor for a patient with CSOM? So your summarized history will be this patient is chronic otitis media of the left side, is it not? So that will be your probable diagnosis. Probably Atticoantral disease by history itself, and by history itself, he is having a lot of chances of having a conductive hearing loss by history itself. That's what we discussed last week.
Yes, sir. Yes, sir.
Why should we examine pallor in a case of CSOM case?
Sir, so in case of long-standing chronic suppurative infection, there might be nutritional deficiencies and
yeah, true. Any patient may have nutritional deficiencies that may cause pallor. Any other specific reason why CSOM will be causing pallor?
CSOM.
Think about causative organism and then tell.
Staph aureus.
So it's a very simple thing. It's not a very difficult question. So if examiner is asking you such a question, he is expecting you to tell in case of complicated CSOM like thrombosis, Sigma-Sinus thrombosis or IJV thrombosis, all the RBCs will be utilized for thrombotic events. So in that case, patient may have a marked pallor. It's true that a patient with jugular thrombosis or IJV, the thrombosis of the Sigma-Sinus will have marked pallor also. Apart from that, CSOM, Atticoantral disease, will actually try and mimic the tubercular disease also, tuberculosis. So in case of tuberculosis also, there is a patient chance of having large chance of having pallor. Usually anemic patients, tubercular patients are pale. So apart from that, you should be knowing the causes of icterus and cyanosis. They might ask in case of CSOM. So let's not discuss everything today. So for a sample, why CSOM case should be having examination of general examination is important. You should know. Okay. Go to the next.
Yeah, here since Saravan said about the tuberculous otitis media, can you Pooja tell us about features of tuberculous otitis media?
Yes, sir. So pale granulation, sir. Facial of palsy, sir. Multiple perforation, profuse watery ear discharge, sir. Hearing loss is present, sir. And,
appropriately, you have to use that. Hearing loss, irrespective of the profound hearing loss, irrespective of the size of the perforation. Even though sometimes the size of the perforation may be small, but the hearing loss may be more because ossicular erosion might be there. So you should always, many pages are there. You should remember 5 P's here. Multiple perforation, pale exuberant granulation. Last week also, Professor Raman discussed this. And it's because there is no bleeding in case of tuberculosis. That's what he said, isn't it?
Yes, sir.
Pale exuberant granulation.
Yes, sir.
And then you have the profound hearing loss irrespective of the perforation, size of the perforation, and profuse discharge. Don't say watery. If you use the word watery, then it will go into the CS of otorrhea.
Okay, sir.
And then last one could be the facial palsy. Do you know why it is multiple perforation here in tuberculous otitis media?
Sir,
Okay. So because the multiple tuberculi deposits submucosally, that causes caseation and necrosis. So initially to start with multiple perforation, later on all these perforation coalesce to form a single large perforation. That is why I said initially maybe the small perforation may be there. Later on will become a larger perforation.
okay, sir.
Right. Yeah, what are the any other condition which has a multiple perforation?
Uh,
One is tuberculosis otitis
Sir,
media
trauma.
and
Sir, trauma. In
trauma.
case
Yes.
of trauma, we'll see multiple perforations,
Yeah.
sir.
All right. All right. Go ahead.
Sir, next, systemic examination, sir. Serious cardiovascular system is S1, S2 heard. Respiratory system is clear, so no added sounds. CNS is normal, and abdomen is normal bowel sound, sir. Next is examination of ear, sir. uh, right ear preauricular region normal, pinna normal, right postauricular region is normal, right external auditory canal is normal, tympanic membrane grade 1 pars flaccida retraction with grade 1 pars tensor retraction, tracheal tenderness is absent, absent on the right side, sir. 3-point tenderness is also absent on the right side, sir.
Okay. So when you look at the tracheal, you said about the tracheal tenderness negative in your patient. In which
Yes.
condition you will get a tracheal sign positive?
Sir, furunculosis
Ah,
and otitis externa, sir.
all right. All right.
And herpes zoster oticus,
All right.
otomycosis.
But preferably furunculosis and otitis externa.
Ex- uh, okay, sir.
Okay. So why did you choose to do the right ear examination first? Why not the diseased ear first?
Sir, sorry, sir.
Why did you choose to do the normal ear patient presents with symptomatic ear on the left, is it not? Right
Yes,
side did not have any symptoms. Is there
yes,
any reason? This is a famous question. See, many
Mm.
questions are not
yes, sir.
there.
Normal.
See, the idea of this presentation is to make sure that you are comfortable during exams, even if the examiner asks you a tricky question.
Okay,
So
sir.
this is one simple question that all of us will like to know whether you know the rationality behind the
Sir
question.
is giving you the clue. Try to
Yes,
take
sir.
up the clue and answer it.
So
So why?
normal ear comparison with so left ear is what the patient is complained, sir. So to
Okay.
compare with the normal ear for the normal findings.
Is that the reason, or Sir has actually told something
Uh,
in between? He has given you the clue.
uh, yes, sir.
So make yourself comfortable in presenting this. Why this case presentation are going on?
So there are two, three reasons. I'll tell the answer explicitly.
Yeah.
One is if you examine the normal ear, actually patient will say, sir, actually my ear is the left. You are examining the wrong ear. So you have to convince the patient saying that, no, I want to examine the normal ear first because if this ear is normal, I'll go to the other ear because if the other ear is infected, I might transfer the infection from that ear to this ear. So that is why I'm examining your normal ear first. And the second important thing is when you examine the normal ear for a child will not have pain or tracheal redness or any sort of a discomfort. And you will win the confidence of the patient so that you can go ahead and examine the left ear first. Left ear
Request
next.
others to mute. Request others to mute yourself.
So this will be appropriate when the right ear is not infected or right ear is not symptomatic. So you will
Okay,
get caught with the examiner if the right ear is actually symptomatic and you are going ahead and examining the right ear,
okay,
which is symptomatic ear. So you should be a little careful in answering these questions. So the problem is if you say like this, examiner will say the other answer, other thing. So now comfortably you are actually having left ear diseased. So you are presenting the right ear and your explanation is appropriate. Okay, sir, I'll do the right ear first because right ear is normal. I don't want to transfer. Suppose if the right ear is infected, so
sir.
will you be able to present the left ear first? Will the exam, because the customer really always we do the right ear examination also first. So you should be a little careful in answering this question. But if you know the answer, the examiner will leave you. So need not worry, even if the examiner twists and says, saying that, okay, why didn't you examine the right ear first? Because that's a custom. If you say that, sir, right ear is infected, so I don't want to transfer the infection from one ear to the other. So this is a
Okay.
small thing, but many examiners do not ask this also. So when they ask this, don't get worried. Yeah.
Okay. So
So right ear examination is normal. Okay. You
yes.
show the you're showing the finding. Okay, go
Yes,
to
sir.
the left ear.
So.
Go to the
Uh,
left ear finding.
So left ear preauricular region normal, sir. Pinna normal, postauricular region normal, sir. And left external auditory canal, there's a single smooth pinkish polyp arising from the posterior superior wall of the external auditory canal. It was sensitive to touch and was bleeding on touch, sir. Tympanic membrane, grade 4 pars flaccida retraction and grade 2 pars sensor retraction. So, tracheal tenderness is absent and 3-point tenderness is also absent on the left side. So,
Okay, now you show in the cursor and show what all the findings you wanted to show. Repeat the findings again.
yes, sir. So, this is a
Can
single.
in my screen, I could not see your PPT. Anyway, I have seen the case already. Just go ahead.
Others are able to see. All the others,
Yes, sir.
if you are able to see, just type yes in your chat box. If you are able to see the picture, please type yes in the chat box. Yes, people are. Krishna Prasad is saying, Swati is saying yes.
Many are saying that.
Many
Okay.
are saying, okay. So
Uh,
you explain the findings here.
Okay, so so left ear findings. This is a single smooth pinkish polyp arising from the posterior superior wall of the external auditory canal, sir. It was sensitive on touch and was bleeding on touch, sir. Then it shows the grade 4 parts flaccida retraction with grade 2 parts tensor retraction, sir.
Okay, so question to the audience: how many of you agree that this is a polyp? If you think this is a polyp, type yes. Type P. If you think this is a polyp, type P. Or if you think this is a granulation, type G. Let's see how many of you are saying polyp or how many of you are saying granulation. Dr. Darshan is saying granulation. Malini ma'am is saying. So many people are saying granulation. Swati is saying granulation. Aishwarya. Malini ma'am is saying polyp. Aishwarya is saying uh, Aishwarya, Safia, granulation. Anushka is saying granulation. Okay. So, Dr. Pooja, can you just tell what is the difference between the polyp and the granulation?
Sir, yes, sir. Sir, granulation tissue. So, can I tell as a definition, sir?
Yeah, you tell. See, this is the classical question that the examiner was. Moment you
Yes,
say
sir.
polyp,
Yes.
they will definitely ask you what's the difference between how did you notice this? How did you come to a conclusion this is a polyp or not a granulation tissue? Yes.
Okay, so polyp, it's an edematous mucosa, sir. It's usually pale and it's with a smooth surface, sir. Granulation tissue will be red in color with irregular granular surface, sir. It will be granulation tissue will be sensitive and painful, sir. And polyp is not sensitive and uh, not sensitive, sir. And granulation tissue will be friable, sir.
Yeah. So so to differentiate, polyp is usually fleshy. So sorry, polypoidal, and it's edematous prolapsed mucosa. That's what we used to say. But
Yes.
sometimes it can be fleshy also. And the polyp usually has its origin from the middle layer or the mastoid mucosa. Okay.
Yes.
And polyp has a very firm base. It has a base, and usually it's pedunculated. Okay. And
Okay.
on the contrary, the granulation tissue will be friable. It's a beefy red, some sort of a angry red tissue it will be. Usually it has small nodules along it, and it bleeds. Definitely it bleeds. The polyps sometimes do not bleed. And yes, granulation tissue usually implies a cholesteatoma.
Sure.
Okay, granulation tissue, if it is there, usually in the perimatrix, you will find a cholesteatoma. And granulation tissue is not usually a standalone mass, whereas polyp is usually a standalone mass. So you should be having some sort of a differentiating points. So which will actually amenable to your decongestion, granulation tissue or polyp.
Polyp, sir.
Polyp usually obstructs the view. Moment you just apply some decongestion, the polyp might shrink.
Yeah.
Okay, polyp may be pulsatile if it is vascular. Okay, polyp may be pulsatile if it is vascular, and these are some differences you should be having in hand when the examiner asks you. So many people feel that it's a granulation tissue, and some of the participants felt it's a polyp. So uh, you can you can leave it here. Let's not make a conclusion that it's a polyp or a granulation tissue. Okay, so you said it's a grade 4 retraction pocket of the grade 4 retraction of the pars flaccida, correct?
Yes. Yes, sir.
Yeah. Can you tell the grading of pars flaccida retraction?
Yes, sir. Grade 1 is pars flaccida TORS classification, sir. Grade 1 is attic dimple, pars flaccida not in contact with the malleus neck, sir. Grade 2, pars flaccida in contact with malleus neck. Grade 3 is partial erosion of attic wall. Grade 4 is total erosion of attic wall, sir.
Okay. So grade 4 is what?
Total erosion of attic wall, sir.
Total erosion of the scrotum. So that will be complete total erosion of scrotum. But you said grade 4 retraction. That's the grade 4. That's what you told. No. Usually, examiners do not like your grading system. They want you to tell what is the exact finding, and then tell the grading if it is asked, or even if you tell by yourself whether it is fine. So you told it's a grade 4 retraction. Can you tell the findings that you see in that picture?
The sputum erosion is
Also, complete scutum
complete
destruction or
sputum.
complete scutum destruction is there. Then
So, complete sputum.
So, Pooja, can you tell what is scutum? You are talking about scutum. So, what is
Out,
scutum?
so it's an outer attic wall, sir.
Outer.
A part of squamous temporal bone, sir.
The part of the temporal bone. Okay.
Temporal bone.
Right. Okay. What are
okay,
other parts of temporal bone?
So mastoid, sir. Petrous
Mastoid
parts.
process.
Temporal, mastoid, petrous, and zygomatic, sir.
There are 5 parts, isn't it?
Yes, sir.
Zygomatic is a part of the squamous. There are 5 parts of temporal bone: squamous,
Yes.
petrous,
Petrous.
tympanic plate, mastoid process, and styloid process.
Yes.
okay.
Right. Go ahead with the finding. Go ahead with the finding now.
So this shows a complete scutum erosion, sir. Along with that, uh,
Anything you missed in the finding?
so ossicles.
Anything else you missed in the finding? So there is a complete destruction of the scrotum. Are you able to visualize any ossicles in the
No,
APT
sir.
panel?
No ossicles.
So you are not able to visualize any ossicles.
Yes.
Any other thing Dr. Pooja has missed? If anyone wants to tell, any participant wants to tell, is the finding complete in the tympanic membrane? Anything else Dr. Pooja missed? Please type in the chat box. So,
Don't hesitate. This is mainly to learning purpose. Whatever you know, you just type it. We'll correct it if wrong thing is there.
Dr. Pooja, you can go to the your slide findings slide.
So parts tense. Yes.
Yeah,
Parts
correct. You so Dr. Partially occluded by granulation. That's what somebody is saying. Any other finding is missing? So, at which point you want to tell about mobility of the drum? Now itself, or you want to tell later?
Sir, now itself, sir.
Are you telling it at the behind? Somewhere else you are telling?
No, sir. I'm supposed.
Okay. So because you missed, suppose you missed the mobility in the examination finding, that means that examiner assume that you have not checked the mobility, and that will be treated like as if definitely you have missed a great finding in the examination, that too in your final exam. So do not panic when you find that. You be honest. You say that, sir, I have forgotten to do. If you have forgotten to do, but if you have done, you have not written, you can always defend, saying that, yes, sir, I did it. I forgot to document. You can even ask the patient.
Sir.
You understand what I'm saying? Be confident in whatever you are saying. Because what
Yes.
happens is, examiner is too senior for you. But at the same time, no, your exam is also very important for you. Without
Yes.
hurting examiner's ego or without leaving your defense, you can always say, sir, I'm very sorry, I forgot. I didn't do also. Please pardon me. If you give me some time, I will do. That is your first level of defense. Suppose you
Yes.
have done and you have forgotten to write it, you can always say, sir, I've done it. Examiner will make fun. No, 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 you are just not honest. That time you can politely say, sir, you can ask the examiner, you can ask the patient also. Now you tell me. Now another important point is, suppose you forget some finding, that is the loophole. So examiner is
Mm.
going to definitely ask what it is. Okay, now you have done fistula test. I'm not going to ask you about fistula test because you have forgotten about the mobility. I'm going to ask examiner, classical examiner will definitely ask what is mobility, how all will you check the mobility and how did you check the mobility? That's the question to you. Yes.
Yes, sir. We'll check the mobility by Valsalva manure, sir.
Okay. So how do
And
you do Valsalva maneuver?
sorry, sir.
How did you check in your patient? Did you check with Valsalva or any other maneuver?
Sir, I checked with Valsalva manure, sir.
So you checked with Valsalva. Okay.
Yes, sir.
Please tell, how did you check with Valsalva maneuver?
Uh, so patient blows his nose and with nose and mouth closed, sir.
So what instruction did you give the patient?
So, sir, I've asked the patient to blow the nose with mouth being closed, sir.
Okay.
Then I checked for the mobility of.
No, that's not the exact thing you will tell the patient. You will tell the patient to take a deep breath, close your mouth, pinch your nose, and blow gently. These are the four definitions you will have to tell. See, because Valsalva itself is a shortcut. Okay. Telling Valsalva for mobility of the drum is actually a shortcut. Uh, uh,
Any other way is there, ma? Valsalva,
Yes,
is routinely are we doing that? Something else we are going to do, isn't it?
sir.
To check the
We'll check it.
mobility.
Sir, autoendoscopy. Sir, or Siegel speculum, pneumatic otoscopy, two with Siegel speculum. Sir.
Yes. So, moment you say Valsalva, you should say all these four things very correctly. One is take a deep breath, close your mouth, pinch your nose, and blow gently. The idea is to raise the nasopharyngeal and middle pressure, and to check whether the eustachian tube is working and whether the mobility of the membrane is all right or not. Because you just make the tympanic membrane to do a workout, small workout by doing that. Okay. So do you know the Seagal's maneuver?
Sir?
Seagal's maneuver.
Yes,
How
sir.
else? Yeah. How else? What is Seagal's maneuver or what is Seagal's pneumatic otoscopy to check the mobility?
Sir, sir,
Can anyone tell? Anyone else in
the
the?
patient sits upright, sir. Then the speculum is inserted into the AC with a airtight seal, sir. Then examiner is observes the TM movement, sir. The speculum bulb is gently squeezed and released to create pressure changes, sir.
Yes, basically it's a bedside test. You insert the small speculum with the rubber bulb. Okay, the
Yes,
speculum should nicely, snugly fit into the external artery canal, and you gently vary the pressure. It's like giving massage to the tympanic membrane. So Valsalva is making the tympanic membrane to do a workout, whereas Seagull speculum is like you make the eardrum a small massage. Okay, if there is no movement, what does it mean?
sir.
If there is no movement, there is no movement in tympanic membrane. What does it mean?
From middle ear effusion or in case
Yes.
of Cholesteatum or large
Very good.
perforation.
Effusion, adhesions,
Yes, sir.
or ossicular fixation. Even in cases of ossicular fixation, also sometimes you may not get the mobility of the tympanic membrane. So, okay, so this is some about mobility of the tympanic membrane. So, what else to ask? So, tell me a little more about the findings. Were there keratin debris?
Before
So,
that, since you
so,
talked about Seagal's pneumatic speculum,
so
what are the other things you can see with the help of Seagal's pneumatic speculum?
So it is used for to do fistula tests, sir, and for
Okay.
magnification, and also
Uh,
to deliver medications, and also in case of power insufflation test, and to suck out secretions from the middle ear, sir.
more also to differentiate perforation from the
Operation.
retraction.
Yes,
To
sir.
differentiate perforation from the retraction also.
Exactly. Yes.
So, what is the magnification of this Seagal's pneumatic speculum?
Sir, two times magnification, sir.
2 or 2.2? Am I right, Siva? 2.2, isn't it?
Yes, sir. Yes, sir. It's not.
2.2.
It's not two, sir.
2.2 magnification.
Yes. And you said something called power inflation, insufflation. What is that?
Yes, sir. Yes, sir.
Power or powder?
Powder, sir. I told powder
You
insufflation.
told powder. Okay. So what does
Yes.
that mean? What powder it is?
Sir, it is usually done to differentiate between adhesive otitis media and a perforation. So we'll use boric acid
Very good.
powder
Very good.
to
Very good.
insufflate, sir. If there is any middle ear mucosa is exposed and secrete mucus, powder will be sprayed over the wet surface. It gets
Puja, Puja, listen, actually, sir already said very good. It means that you have to stop with that.
sir, I
Then
couldn't
next, oh,
hear.
you couldn't receive that. Okay, all right.
Sir, voice is breaking, sir. Sorry,
All
sir.
right. இல்ல
Oh,
இல்லம்மா in examல they're saying
Uh,
that it means that you know that then அடுத்ததுக்கு போயிடுவாங்க.
okay, sir.
yeah.
Sorry.
Always
Actually,
listen to the examiner.
yes.
Yes.
If they are asking, then answer. If they
Okay, sir.
ask you to stop, stop in that way. Even
Okay,
though
sir.
if you know the answer fully, you stop with that.
Okay, sir.
These are the small, small things you should remember, all of you.
Okay. Is the granulation pulsating?
No, sir, it was not pulsating, sir.
Okay. If it is pulsating, what could be the cause?
So in case of glomus,
Glomus rarely pulsates, but okay, I will agree. Glomus. Any
so,
other causes it pulsates?
uh,
Pulsating
so,
granulations
so
or a
pulsate,
pulsatile discharge from
so
body.
jugular bulb, high riding jugular bulb.
Usually, once it comes into the skull base, no, usually foramens through the pulsations will not be really, especially for the venous system. But I agree, glomus or transmitted pulsations, then anything else.
So in case of so sigmoid sign, Dyson,
Think in terms of brain.
uh,
Suppose there is an underlying cholestoma here and there is pulsating granulation or pulsatile discharge.
so
This pulsatile discharge could be a transmitted pulsations from the brain itself. So in that case, there is erosion of the tegmen.
okay,
Okay, in that case, there is erosion of tegmen. Pulsatile discharge, apart from erosion of the tegmen, it could be because of the reservoir sign. Granulation, especially in the attic, in the epitympanum area, you should be keeping in mind that this is already eroding the tegmen and going into the dural space. Okay, so these
okay,
are
sir.
some things. See, we can prolong the discussion in this finding itself another 2 hours or 3 hours. So I don't want to
So,
keep boring you and uh, and to prolong the discussion. See, everyone should be knowing what type of cholestoma. Is this congenital cholestoma? If this cholestoma, is this
so,
congenital cholestoma
sir,
or is it acquired cholestoma?
so
Or
it's
is it a mesotympanic cholestoma or is it a posterior epitympanic cholestoma? So if it is whatever you answer, do you think the cholestoma extends medial to the incus or not? So why do you think this cholestoma is extending medial to the incus? So do you think that now this cholestoma is extending into the facial recess? Do you think this cholestoma can go to antrum? All these questions can arise from here itself. So you should be able to answer, but let us not go into all these things today. But these are the questions that they might ask you probably when somebody else presents the year finding next month or next time. So we can reserve these questions to the because we do not repeat all the questions again. Okay.
Correct. Correct.
Uh, sir,
And you said
okay.
about the classific, I mean, retraction grades of pars flaccida retractions, and you have named it as a task.
Yes,
So what
yes,
about pars tensa? You said pars tensa grade 2, isn't it?
yes, sir.
Again, you have to tell about the finding, and then so you are telling that it's a grade 2. Okay. So what is the
Okay, sir.
name of the pars tensa retraction, and tell about the grades?
So past tensor retraction is a sales classification, sir.
Okay.
Grade one slight retraction of pars tensor. Grade two is retraction onto the incus. Grade three retraction onto the promontory, but not adherent. Grade four is adhesion onto promontory. Grade 5, atelectic tympanic membrane with perforation.
Usually 4 grades only, isn't it? Why you are using the other one? So where did you read this one?
Sir,
So the fourth
sir.
one is adherent to the promontory.
Okay, sir.
Okay. So you said about grade 1, isn't it? What are the features of grade 1 retraction of pars tensa?
Uh, sir, uh, dull
Ah.
lustrous tympanic membrane, sir.
Hmm.
Distorted cone of light.
Hmm.
Dominance of lateral process of malleus.
Hmm.
Apparent foreshortening of handle of malleus.
Hmm.
Prominent uh, anterior and posterior malar folds.
Myelin fold. Right. Okay. Right.
So there is no meringosclerotic patch here. Okay, if meringosclerotic patch is there, question will come into what is meringosclerosis, what is tympanosclerosis, what are the grading systems for meringosclerosis, tympanosclerosis, and all. It will come. Sir, any other faculty here, Doctor? Sir Vijay Sundram, sir, you want to ask some question in the finding? Dr. Aparna Das, you want to ask some question in the finding?
In between, Venkat also was joined. Venkat
Ah.
and Geeta, Dr. Geeta also joined, but I don't know whether they are there or not.
Venkatramanan sir, name I'm finding, sir, now. Venkatramanan sir, I'm finding.
Yeah,
Geeta madam.
still
Geeta
Yeah,
madam.
I'm
haven't.
here. I'm here, sir. I'm here, sir.
Sir, any question you want to ask, sir?
Hello?
Yeah,
Hello?
I will ask, sir. I will ask, sir.
Yeah, it's audible. Dr. Vijay is here.
Yeah, audible,
So,
audible.
Dr. Swa?
Yes,
Yeah,
sir.
yeah.
Audible, Vijay.
Yeah, regarding, yes, okay. All the questions, this interaction, only basically the interaction pocket going for colostoma, it is a question. How this is a self-cleansing, non-self-cleansing property of interaction pocket. Regarding this, the examiners may ask some questions.
Yes.
Sir.
Okay, sir.
That thing the candidates, yeah.
Okay, sir.
That is the question I want to ask. Yeah.
Okay, sir. So, with your permission, we'll go to the next slide. So,
Yeah,
we'll go
sure,
to
sure,
the
please.
next part of the examination. Yes.
Sure, please, please.
So can I move into the next
Yeah,
slide?
please move to the next. Move to tuning fork test.
Okay, sir.
Yeah, please move to the tuning. Yeah, present your tuning fork findings.
Yeah, maybe another 20 minutes, Shiva. Now it's 2:40.
Yes,
Okay,
sir.
sir.
Maybe 3:10 we'll find out, right?
Yes, sir.
Okay, right. Sorry.
Sir, tuning forks test, sir. Rennie's test, right side positive at 256 hertz and 512 hertz is also positive and 1024 hertz. Rennie's positive on right side, sir. And on left side, Rennie's is negative with 256 hertz, 512 hertz and 1024 hertz, sir. Then Weber's is lateralized to left. Absolute bone conduction test is not reduced on both sides. Vestibular function test is normal and fistula test is negative.
Okay, so your Rennie's test is negative in all three frequencies, correct?
Yes.
So 256 also it's negative on the left side,
Yes.
and 512 also negative, and 1024 is also negative. So how do you classify early, moderate, and severe based on your Rennie's test?
So 256 is early, sir. If both 256 and 512 is negative, it's moderate, sir. Uh, in case of 1024 hertz is negative, it's severe, sir.
Okay, so how did you do Rennie's test?
Sir. So Renee's test, first patient consent should be taken and explained to the patient. Then tuning fork is hit over the bony prominence. Then it is placed over the mastoid of the patient's ear. And when the patient stops hearing, it should be placed near the external auditory canal, sir.
So how do you avoid false positive tests? How do you avoid false negative or false positive Rennie test?
So in case of modified knee,
And why is Rennie considered to be a comparison test? Is it a comparison test?
yes, sir.
What do you mean by comparative test?
So, air conduction and
Come again?
compared with the bone conduction, so
Yes. So
Yeah.
actually, it compares air conduction to the bone conduction in the same year. It does
yes.
not. What does it not measure?
So
It does not measure the
measure.
absolute thresholds.
Okay,
Okay.
sir.
It cannot measure the absolute. Though threshold estimation is also possible with Rennie. So how do you do threshold estimation with Rennie?
Modified Renee's test, sir.
You don't really
By
call.
Uh-huh.
sorry,
Okay, you go ahead. Tell.
Pooja, as Saraman sir said, actually based on the monooral comparison of air conduction and the bone conduction, isn't it?
yes, sir.
The Rennie is threshold comparison and
Sir.
modified Rennie is loudness comparison.
Okay, sir.
Right? Simultaneously, you are keeping it close to the external canal and then mastoid process. Ask them which one is louder. That's a modified Rennie.
So
Correct, sir. Correct, sir.
Am I clear? Yeah. Am I clear,
yes.
Pooja?
Yes, sir. Yes, sir.
See, Rennie means you are comparing the threshold. Monooral comparison of threshold.
Okay, sir.
First, you are going to keep it on the mastoid process. Once the sound stops, bring it closer to the external canal, 1 centimeter lateral to that. And the prong should be parallel to the canal.
And, yes.
Yeah. So in that way, you have to keep it. This is the threshold comparison.
Okay, sir.
And the second one is a modified Rennie. That's a loudness comparison.
Yes.
Right. You know, one
So-
more of us. Yeah, go ahead, sir. Go ahead.
So examiner will ask what's the proper technique? How will you avoid false tests? So how do you avoid? Sir, you wanted to tell something, so you tell that first.
Yeah, that's a false negative. So when you get a false negative Rennie, in which condition you get the false negative Rennie?
Sir, false negative in case of profound unilateral sensorineural.
Very good. So profound unilateral sensorineural hearing loss, you will get a false negative Rennie. So then how can you differentiate whether it is a sensorineural hearing loss or conductive hearing loss?
Weber's.
We need to go for a Weber's test. Very good. Right, that's all. I just
Yes,
want.
these are the questions. I'll tell you some questions. You prepare answers. What is the proper technique? How will you avoid false results? What happens to Rennie in profound unilateral sensorineural hearing? These are the standard questions exam. Profound unilateral sensorineural hearing loss. What happens to Rennie in mixed hearing loss? And What is false negative Rini? That's what sir asked you. Why to interpret Rini and Weber together? Answer this question. Why do you interpret Rini and Weber together?
Sir, to differentiate whether it's a conductive hearing loss or a sensorineural hearing loss.
Yes. So Rini Weber tells the laterality, based on which Rini will tell the type of loss. So it's a sidekick. Basically, they go together. Rini and Weber go together. You need to do the Weber to tell the laterality. Based on the laterality, you do the type of hearing loss. Rini
Okay.
alone can be sometimes loss. And what are the limitations of Rinne's test? And why you use 512 hearing, 512 hertz hearing and not 256 or 120, 1024? And what is the effect of ossicular erosion on Rinne? All these are simple questions that they might ask. Probably will, if you can note down, somebody can note down all these questions, and then they can find out some answers and put. I'll be happy.
Okay,
Okay,
sir.
let's
Ma'am,
not
Vijayana,
wrong
Vijayana,
on.
mute பண்ணுங்க.
Hi.
Mute
Yes,
பண்ணுங்க.
okay.
Sound வருதுங்க.
So renewing test, if you answer very nicely, and if you answer a tuning fork test, the examiners will be very happy. So we'll go ahead with the next examination findings. Yes.
So examination of nose, sir. External framework of nose was normal, sir.
Any
Vestibule
positive
normal.
finding is there?
No, sir. No positive findings, sir.
Okay. Go to the next slide. Okay, next slide.
Regarding Weber, one more point I just want to add here. Rini, we said about it's a monaural comparison, isn't it?
Yes, sir.
And here it is a binaural comparison of bone conduction.
Okay, sir.
Weber based on the binaural comparison of bone conduction, as Professor was said, the laterality, that point, isn't it? So
Yes.
it's a binaural comparison of bone conduction.
One connection. Okay.
Okay, right. Which is sensitive, Rini or Weber?
Sir,
Yes, right.
Weber is
Don't
sensitive.
hesitate. Yeah, right. Weber is highly sensitive. How much sensitive it is? How much loss can I easily pick up?
7.
Always tell the range, right? 5 to 7 decibel.
Yes.
Okay.
Rini is mainly examiner dependent. Examiner has to do it properly.
Okay, right.
Okay, very good. So go to your next. Any other positive finding is there?
No,
So
sir.
we didn't discuss about the fistula test, all those things. So let us not keep on discussing in detail. So let us move ahead faster. Yeah. So go to your probable diagnosis.
Yes. So, a probable diagnosis is left chronic suppurative otitis media, squamosal type, active stage with severe conductive hearing loss with no complications.
Without any complications. Okay.
So,
Fine. Nowadays they say chronic otitis media. They don't use the word suppurative. The new classification comes like that. But
Yeah.
if you say like this, that is fine. No issues.
Always better to avoid suppurative now. It's now called as a chronic otitis media.
okay, sir.
Suppurative is a chronic otitis media.
Okay, sir.
Okay. Now, tell us the definition of chronic otitis media. What does that mean?
Sir, it is chronic inflammation of mucoperiosteal lining of middle ear cleft, sir, with continuous or persistent otorrhea with perforation.
Okay, through a perforated tympanic
Through a
membrane.
perforated tympanic membrane.
So with or without cholesteatoma. Suppose you find no perforation in congenital cholesteatoma. Do you really call it CSOM? And one of the editions of shampoo, no, it accepts without perforation also as a diagnosis, as a definition for CSOM. because congenital cholestoma by definition does not have perforation. So they accept that also as a part of your CSM definition. And give definition for cholesteatoma.
So cholesteatoma is a three-dimensional cystic sac-like structure lined by stratified keratinized squamous epithelium lying on a fibrous stroma containing a desquamated keratin debris.
Okay, at least there are 3-4 definitions. You mark up the name of the definitions person, and then at least tell one definition correctly with the name of the person. Okay. Now, assuming that this is squamous disease, how will you proceed with this patient?
சிவா ஒரே ஒரு இப்போ இதில் கொலஸ்ட்ரிடமா ஃப்ளேக்ஸ் நம்ம பார்க்கல.
Yes, sir.
பட் இது ஆக்டிவ்னு சொல்றதா? இப்போ ஏன்னா அந்த அந்த கிளாசிஃபிகேஷன் படி கொலஸ்ட்ரிடமா இருந்தால் வில் கால் இட் அஸ் ஆக்டிவ் அண்ட் இதுதான் ரிட்ராக்ஷன் இல்லை, ஐ மீன் இன்ஆக்டிவ்.
Yes, sir.
இப்போ நம்ம கொலஸ்ட்ரிடமா ஃப்ளேக்ஸ் பார்க்கல. நான் இனிஷியலாக தே ஹேட் கொலஸ்ட்ரிடமா ஃப்ளேக்ஸ்.
Yes, actually, this cholestoma flakes, they should have presented in the finding whether it was sucked out or whether some smell of cholestoma is present and all. Regarding the retraction pocket itself, and regarding the finding itself, I wanted to ask whether keratin debris was present or not. You should have clearly said there are no keratin debris present.
Yes, sir. Right. Okay. Right.
So all that will add to your definition, whether diagnosis, whether it is active or just a chronic otitis media. Okay. So how will you proceed?
Sir,
what's the next step? So you assume that this is a squamous disease.
Yes, sir. So investigations.
Yeah.
Always keep that in mind. Don't forget that. Don't jump into the surgery directly. So investigate it and then go for the treatment. So what are the investigations? Yeah.
So autoendoscopy was done, sir.
Before I forget, I'll tell you one thing. There is something called, you present the 3-point tenderness in the examination itself. So
Yes.
Third edition Paperella, no, the older editions of Paperella and older editions of Scott Brown gives what exactly is 3-point tenderness. If masseter tip is tender, if the antrum is tender, and if the posterior border is tender, what is the extent of the disease? In pre-antibiotic era, this masseter tenderness and 3-point tip tenderness is very important. So go back and read all those things, okay? It's given very well in Paperella. Old examiners will definitely ask that.
Okay, sir.
Yeah, fine. So what all will you do now? What next you will do?
So, sir, autoendoscopy was done, sir.
In autoendoscopy, what will you, or microscopy, what will you do? You want to do autoendoscopy. The next question will be, why not automicroscopy?
Yes.
Sir,
So you should have a difference. Autoendoscopy, automicroscopy. How is it different?
so autoendoscopy is OPD.
Yeah, autoendoscopy, usually it's a readily available instrument. Rather than microscope, autoendoscopy is easily readily available. Then what are the differences? So it's very
Sir,
simple. No, you can always tell in microscopy, my both hands are very free.
Okay, sir.
Then
This every conference they are talking about, isn't it?
Sir, in
Difference
autoendoscopy,
between
yes,
different.
sir, so in autoendoscopy, field of view will be wide, sir, and
Very good.
automicroscopic will be a narrower field of view, sir.
Okay, then
In autoendoscopy, it will be viewed from all around.
what is one microscopy advantage?
Microscopy advantages.
What are the advantages of a microscope?
So better for
Both hands are free.
free, sir.
Then you will have a definite 3-dimensional view. Okay.
Yes.
So these are the and coaxial illumination. So three-dimensional view, coaxial illumination, and both hands are free. Is actually, and many of us are used to using auto microscopy for here. Auto endoscopy, what is the advantage? Advantage is
So it
readily
is.
available. It has
Uh,
very good illumination. It gives a high and close-up magnification. Okay,
okay.
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 So you will do auto endoscopy or auto microscopy first. Then what's the next?
So next is pure tone audiometry. Which is,
So, what are the additional features that you will show apart? See, in tuning fork itself, you found out it's a severe conductive hearing loss. Okay.
okay. So
What other things it will tell apart from these findings?
The Kyoto audiometry.
pure tone audiometry is usually done to know the degree and uh,
Yeah, degree you already told by sense by tuning fork itself. If it is negative
for
for
medical legal
medical legal purpose, that is for sure.
will
Then what additional information the audiometry will give? Audience can type in the chat box. These are all very simple questions. Definitely they will ask. What additional information auto microscopy will add apart from your you did autoscopy, auto microscopy or auto endoscopy? What things it will add? Now, yes, somebody has typed it in chat box. Very good. Airborne gap. Airborne
okay.
gap, the threshold, that's what we told, no?
Yes.
The tuning fork really does not estimate the thresholds of air conduction on bone conduction, whereas the PTA will actually estimate the thresholds of air conduction, bone conduction, and you will know to get to know what is the airborne gap for sure. And apart from that, you will have your medical legal implications also. Then, what other investigations you want to do?
Sir, HRCT temple bone.
Okay, what additional information it will give you?
So extent of the disease,
It extends into antrum,
ossicular,
mastoid, or sinus tympani. Then what
yes,
else?
ossicular integrity,
Ossicular status. It will definitely give you ossicular status. Then,
any impending complications.
yes, any lateral semicircular fistula or tegment erosion or facial canal erosion, it will give. Then, what else it
Uh,
will give?
so
It
to
is like a
identify
Google map before you start driving, is it not? Where is
surgery, danger signs before to identify
Yeah. So,
any
what is
danger
the
signs.
importance about your um, pneumatization? Why you want to know the pneumatization?
So
Why do you want to?
pneumatization,
Why, why do you want to see
pneumatization,
in CT scan? You wanted to see pneumatization also, is it not? Why do you
yes,
want to
sir.
see pneumatization?
So if the mastoid is well pneumatized, it's a good ventilation, and that indicates less chance of chronic infection.
Okay, I will leave it to you. And why you didn't tell X-ray of mastoid?
X-ray mastoid, yes, sir. Yes. Sorry, sir.
Why you didn't tell X-ray of the mastoid? What all information you will get from the X-ray of mastoids?
So X-ray of mastoid, we see about uh, degree of development.
Again, you see the pneumatization. You will see the
Yes, sir.
sinus plate and the
Tegment,
tegment
Tegment.
plate.
tegment
So,
plates.
how does it help you in seeing the sinus plate and tegment plate? It helps you to tell whether it's a contracted mastoid
Yeah.
or a normal
No,
mastoid. What do you mean by low-lying dura? What's the definition of low-lying dura? What's the definition of anterior-lying
Forward sinus.
sinus, forward-lying sinus?
low lying dura.
So these are
So
definitions. Definitely, you can always say something you can say, but there are definitions. There are gradings for anterior-lying sigmoid also.
And cavity also you can see.
Yes, sir.
Do you know the DD for cavity?
Large cavity.
Large
large
cavity.
Sorry,
cavity,
cavity,
also
cavity.
in case of cholesteatoma, large antrum, sir. In case of eosinophilic granuloma, in case of tubercular mastoiditis,
Mm.
uh, and malignancy of
Malignancy, last I have to tell. Before that, a few other things also.
last
Aneurysmal
and
bone cyst. Yeah.
sir. Uh,
Multiple myeloma, eosinophilic disease, aneurysmal bone test, tuberculosis, large antrum by
Post
itself,
surgery.
post surgery. And once you say post surgery, what's the difference between post surgery and
Post-surgery disease. Yeah.
disease? That difference you tell. You should be telling this. It's a very easy question. And not easy. Definitely they'll ask this question.
Sir, so can you repeat the question, sir?
What is the difference between a post-op cavity and a disease cavity?
Okay, so so
Post-op,
post-op disease cavity will be irregular
Very good.
granulating with patches, sir, with mucosal
No,
patches,
no.
sir.
See, அதெல்லாம் உனக்கு எப்படி? How can you see in the X-ray? Mucosal patch
In
granulation, how
X-ray,
can you see? So you
okay,
started with the good one. There's the irregular edges.
granulating.
Irregular edges.
Okay, sir.
So you can see a cavity in the X-ray. Or if the
Yes.
edges are irregular, then it could be a diseased one. Because of the disease, it's irregular. And whenever you do the surgery, you do a regular sarcorization. That's the most important always, isn't it? It will be regular margin in case of surgical cavity.
Okay, sir.
One, then
In case of normal cavity, it will be smooth edges, sir, and adequate volume will be there, sir. Volume, it means it looks
Mhm.
in X-ray. It looks um,
So the first point will be irregular in case of diseased one, and regular in case of surgery one. So I mean post mastoid cavity, and then you'll find the cottonwool appearance within the cavity in case of cholesteatoma, whereas it will be a translucent in case of surgical cavity, and thin sclerosis will be there in case of diseased one at that periphery, whereas here it is not like that. These are a few difference between the diseased cavity and surgical cavity.
okay, sir.
so you left with HRCT temporal bone. You wanted to see the extent of the disease, ocular erosion, and you want to see the pneumatization. We talked about X-ray. And then what will you do? You will control the infection. You will do oral toileting. You want to give some topical antibiotics, or you want to treat little complications. If the patient has intracranial symptoms, signs, admit and give IV antibiotics, and then take the cholesterol for surgery. What is the surgery you will post in OT notes? In OT list, what will you post and what consent you will take from the patient? What's the name of the surgery you will take the consent for?
So, canal wall down
No, I'll
mastoid.
tell you the answer. This answer may not be correct with a lot of examiners. You will
Exactly. It differs from exams to examiner.
So do not worry. If you
Yeah.
say you will post for a modified radical mastectomy, you will be right. There's no problem. But the answer that I would be expecting is tympanomastoid exploration under GA.
Okay, sir.
Definitely it's a tricky question, and every examiner expects a different answer. Am I right, Shiva?
Yes, sir.
No.
That is where students will get really embarrassed, and we also as internals and even
Amma.
as externals sometimes enjoy, sometimes feel embarrassed also along with them.
Embrace also. True.
Because these are the things students should also be able to navigate easily.
Exactly. Oh.
See, examiner is not examiner. Examiner does not want to fail you. Examiner wants to see whether you will be able to answer the patient, able to answer the media, able to answer the court of law. That's all. So you should be able to navigate all this. Once you are confident in your subject, you will be able to navigate all these things nicely. That's what I personally feel. Okay, okay. So tympanomastoid exploration under GA.
Yeah.
Okay. So
Another 5 minutes we'll go with Siva. Another
Yes,
5
sir.
minutes. Yeah.
Yes, sir.
Okay.
Some definitions. What is MRM? What is modified radical mastectomy?
Um,
So if you don't know, you please mug up some. You please mug up some definite answer so that you will be able to modify radical mastectomy is a disease, is a surgery done to eradicate the disease from the middle ear and the mastod cavity and the middle ear cleft,
yes.
and
Uh,
with reduction of the posterior canal wall, making the mastod cavity and the middle ear cavity and the external canal into a single cavity.
okay.
Okay, with or without reconstruction of the ossicles. So this is the simplest definition for modified radical mastectomy. This covers essentially everything. Though there may be difference, if you cover this, this is very important. And
Okay.
what is inside-out mastectomy?
The 4 E's they said, isn't it? Eradication,
Yes.
exenteration,
And then exterior.
exteriorization, and epithelialization.
Yes.
Yes.
4 E's.
Yes.
So sir told the 5 P's today
Yeah.
and 4 E's today. And last week, Siddhanand sir told 5T for referred otology. Remember all these. This will all
Super.
come very handy. Okay.
Okay. So,
So, what is the
in,
what are the boundaries for a cortical mastectomy? What are the surgical limits for cortical mastectomy?
sir, the Tegman superiorly, sir.
Okay. Superiorly tegment, anteriorly the posterior wall,
Posterior.
posteriorly the sigmoid, inferiorly
And
the tip of mastod, medially the labyrinth.
So better to say Tegman and try because Tegman you got tympani also.
Yes, sir. Yes, 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 sir. Correct.
okay.
Yeah.
Okay. Sir.
Okay. These are the standard. What is combined approach tympanoplasty? What are the surgeries included in combined approach tympanoplasty?
The common approach to no class.
Okay, I'll tell you
So
the
the posterior tympanotomy, sir.
very good. Cortical mastectomy first,
Okay.
then posterior tympanotomy, then
Yes, sir. And then Atticot.
epitympanotomy, atticotomy or epitympanotomy. Three,
Epitympanotomy.
two more. Lateral tympanotomy, that means elevation of the tympanometal flap, and canaloplasty. So I repeat, combined approach tympanoplasty has 5 procedures in common. One is cortical mastectomy, epitympanotomy, posterior tympanotomy, lateral tympanotomy, and canaloplasty. They'll definitely ask what is the definition for posterior tympanotomy, what are the boundaries for posterior tympanotomy, what all structures you will see by posterior tympanotomy, and what is extended posterior tympanotomy. That they will definitely ask. Another important thing that they'll ask is what is facial ridge. Pooja, can you tell what is facial ridge?
Yes, sir. It is that part of posterior bony wall which lies lateral to the vertical portion of the facial nerves.
Okay, what is facial bridge?
It is that part of posterior canal wall which lies lateral to adductors and anterus.
Lateral to Aditus.
Aditus.
Adductus.
Bridge is lower down is Aditus, above is that bridge part of it. Yeah.
What is posterior buttress? What is anterior buttress? These two.
Yes. Posterior buttress is.
So these are all different questions. You should not answers. You should mug up. If they ask this question, no, it is like sure lottery to you. Immediately answer, and examiner will be happy. Okay,
So it's.
Sir. With this, I will stop, sir. I
Yeah.
will stop asking questions, sir.
Yeah. I think we can stop with that. So anterior buttress, you do know, Pooja? Anterior posterior buttress. Yeah, tell.
So posterior buttress is a bony ridge formed by lateral attic wall, sir.
No. Again, that part of the posterior canal wall, which is like close to the floor, that is a posterior buttress.
Floor of the yes.
Then the anterior buttress, again, that part of the posterior canal wall,
Which
close to the
lines?
roof, attaches to the roof. That part is it. Therefore, all these things are different name for the posterior canal wall. First you have the anterior buttress, then you have the bridge, then you have the ridge, then you have the posterior buttress. Right. Sir asked about the boundary for facial recess. What is that? Boundaries for facial recess.
Sir? So
Boundaries
sorry,
for
sir.
facial.
So facial
Boundaries.
recess, facial recess boundary, sir. Medially, it is bounded by vertical segment of facial nerve, sir.
Okay.
Laterally by chorda tympani nerve, sir.
Very good.
Superiorly by but incus buttress, sir.
Incus buttress. Short process of incus buttress. Okay. All right. I think we can start with that, Shiva.
Yes, sir. Sure, sir.
I think
Pooja
so.
will
Thank
be
you.
very tired. Pooja, she'll be telling, please leave me, sir. Give me a
No,
pass.
no. They're all happy in having this discussion like this. Hopefully, all the people who have joined from the beginning, they are there till now. So, thank you, Professor Siva, and thank you, Dr. Pooja, and other participants who are participated today. And
Thanks for the
probably
opportunity, sir. Thanks for calling me.
it's
Thank
a
you, sir.
pleasure always.
Thank you,
Maybe
sir.
next month, some other today MGMC and Jibbar have done that. Maybe next month we'll ask Sitanand and Prabhu to do that, isn't it?
Yes, sir. Sure, sir.
Yeah. So next month we'll not next week, next month.
Next month.
Too much of academic also will be the burden.
Yes, sir.
So we'll have it probably December 2nd week. We'll have it.
Yes,
Is
sir.
it
Sure,
okay?
sir. Sure, sir.
Okay. So we'll convey this to other colleges also, so that they also participate in large number.
Yes, sir. Sir, participants can comment their feedback in the chat box, and then they can give us a feedback, sir. Open feedback.
True. Yes. Always, every session should be given by the feedback so that we can improvise. Next time, if anything they wanted to change or anything is there, you can try to improvise that also.
So thank you for the opportunity, sir.
Pooja, you did very well. For the first time presentation, you did very well. I'm very happy that you came forward to present the entire case in Zoom meeting for the benefit of you and for the benefit of all of us. And I congratulate you wholeheartedly that you will become very great ENT surgeon. Okay.
Thank you. Thank you so much, sir.
Thank you. Thank you.
So, Vasister Royal Brahmarishi, and Mari, the professor head of Jibbar says about that. So, all the best, Pooja.
Thank you, sir. Thank you so much.
Right.
Sir, all participants can slowly leave the meeting, sir, giving the feedback. I will also leave the meeting, sir. After reading the feedbacks, I'll leave the meeting, sir.
Yes.
Yes, sir. Thank you, sir.
Thank you. Thank you, Professor Siva. Thank you, Professor Siva.
Thank you, sir.
Right. Okay. Well, give the feedback and then sir. இதுல யார இருக்கான்னு தெரிஞ்சு மொபைல்ல ஐ அம் ஜஸ்ட் ஹேண்ட்லிங் இட் யார் இருக்கா என்று இப்பதான் விஜயலாம் போறாரு
கீதா மேடம் இருந்திருக்காங்க இப்பதான்
அதான் சொல்றேன் எனக்கு தெரியல
நீங்க சொன்னீங்க நான் வர இல்லன்னு வேற சொல்லிட்டேன்
நடுவுல வந்துட்டு போயிருக்காங்க
எஸ் சார் nobody is giving feedback everybody is leaving அவ்வளவுதான்